All right, welcome back. For upper extremity, we're going to start with the shoulder complex. And so the way that we're going to introduce the shoulder complex is first we're going to go through what joints make up the shoulder complex. And then we're going to hit some osseous landmarks so that we can, in our palpating, get a little bit more familiar with palpating extremities, palpating in this instance the shoulder. It's been my experience that a lot of students when they come into the extremities course haven't spent a whole lot of time working on extremities, and so we need to familiarize ourselves, make sure that our hands know what they're touching. So to start, we're going to define the 4 joints of that shoulder complex. So we'll kind of move the humerus off to the side here. This is the clavicle here. And so the most proximal joint that contributes to the shoulder complex is the SC joint, the sternoclavicular joint. So the proximal aspect of this clavicle articulates with the manubrium that would be sitting here as kind of represented by my index finger. My model doesn't have a manubrium on it. So we have that proximal aspect of the clavicle, and then we've got the manubrium. Those two bones make up that SC joint. And then we take that clavicle as it courses distally or away from the body here, and we have that articulation of that distal clavicle with the acromion process, which is a projection of this entire scapula here. So way out here we've got that acromion process and that distal clavicle. That's our AC joint. So SC joint, AC joint, and then we'll bring humerus back into the picture here, which most people think of when they think about the shoulder joint is just this articulation, the glenohumeral joint. So we've got the humeral head and then the glenoid fossa contributing to making that joint itself. That leaves the last joint here being the scapula's articulation with the thoracic cage. So this is the anterior aspect of that scapula, as if our patient were lying flat on their back facing us. And so that thoracic cage sits here, and that's a pseudo joint. There's no osseous articulation. It's comprised of that scapula moving about the thoracic cage, and its stability and its motion is dictated by the muscles that support it. And that's very important for us, because if muscles are the cause of stabilization for a joint, then anything we do to cause those muscles to become overactive or underactive will impact the stability of that joint. And if you look at these joints, one thing that they've all got in common here is that they rely on that scapula to be stable. If the scapula is not stable, the scapula then impacts the articulation of the glenohumeral joint, certainly the articulation of the AC joint, and then by proxy, the articulation way over here of that SC joint. So scapular stabilization is hugely important for the stability of the shoulder complex. Without scapular stabilization, the shoulder complex becomes weak and prone to injury. So what we need to look at here from an osseous standpoint here is what are some things that we can identify quickly that give us an idea of where are we within this shoulder complex. And so the first thing we're going to do is we're going to look at that proximal clavicle. So we've mentioned that here. I'm going to use my K-State purple here, and we'll outline some borders of that joint. So here is that proximal articulation of that clavicle. So what I would like, and then if I have it, I'm not going to color my finger, but if I had a manubrium here, I would color it as well. So what I want you to focus on, though, is the palpation of that clavicle. And so in doing that, we would lay a hand over here, and then we're going to challenge. We're going to bring that humerus, and you'll see after we go through this, we'll do it on a patient. I'll show you that. We'll move our patient's arm a little bit, and we'll get some motion actually out of this out of this SC joint. Those are the beginning stages of our palpations of that joint. So it's important for us to be able to just get a good feel of, hey, this is how this joint is moving, and that this joint is moving. And then we need to realize as we move distally that the clavicle is not a straight line. So the clavicle has this kind of a jog. So if we were to palpate straight over, what I've seen is sometimes people land over here and they land on that coracoid process that we'll talk about here in just a minute, which can be tender for our patient and also give us some false information because it's not really articulating with anything. So we need to make sure that we're coursing over and realizing that clavicle is jogging, it is moving back, and that it is articulating over here with the acromion process of the scapula. So here is that acromion process. There is the clavicle. This is our AC joint. Right, and so these joints here, we'll talk about it more in lecture here. There's differing types of joints that exist here. Convex on concave, concave on convex, and then just a strict kind of abutting of those joints that is stabilized by ligamentous structure. Again, we'll dive into the anatomy portion a little bit more in depth in a lecture standpoint, but I do want to at least show you these articulations here. Next, we'll jump down to this coracoid process. This is an important osseous projection for us. It is an awesome attachment site for some muscles, so we need to be aware of that. This is also a really, really, really tender point on our patient. So if we are palpating this if we are palpating this osseous landmark, we need to be aware of that. So we've got pec minor attaching here, we've got coracobrachialis attaching here over on the medial aspect, and then we've got the short head of the biceps attaching at this point here. So we've got a lot of attachment points coming over on this. Remember, we're getting stabilization of the scapula through muscular attachment, so these are contributors to that. Certainly an overactivity of a pec minor is going to tug and pull that scapula in a little bit or cause it to protract. And so we do want to make sure that we know where those muscles are attaching and we understand their importance and their role in that shoulder stabilization. Next is the humerus, the glenohumeral joint. So remember, we've got a great big old deltoid that's sitting over the top here. And so because of that, it is a little bit difficult to palpate the head of the humerus. But what happens is that deltoid comes down and it attaches to kind of the shaft of the humerus, which means that as that deltoid tapers off and turns into a myotendinous junction and attaches to that head or the shaft of the humerus here, we actually feel that shaft of the humerus, and then we can use that to help us walk up to the head of the humerus. So as we land on that head of the humerus, then we can kind of feel the joint as it exists here. Now remember that we do have soft tissue in this area and it can be kind of tender, so we need to use soft hands as we're coming down through and palpating. But we do have that glenoid fossa here. We do have the humeral head here. Now, one thing I want you to understand, one thing I want you to pay attention to is if we look here. So we'll try to outline it here and make it a little bit easier. Here is the outline of the glenoid fossa. Okay. I want you to look at the outline of that glenoid fossa, and then I want you to look at the head of the humerus and realize that that glenoid fossa is really small in comparison to the head of the humerus. And so some anatomists call it like a golf ball on a golf tee, with the golf ball being the head of the humerus there. And so what the body does is says, well, we need to add stabilization to this joint, and they add a labrum in there. And we'll talk about that again a little bit more in lecture, but we do need to make sure that we're addressing that the stabilization of that GH joint is 50% of the depth of that joint can be contributed to the labrum, and so we do need to be aware of that. If we flip this whole thing over, so now we're staring at our patient's back. One thing I want you to take note of here is that we've got the spine of the scapula here, a great landmark for us. We can use that spine of the scapula to identify the scapular orientation, but then to also follow all the way out to the acromion process and help us find that articulation with the distal clavicle. So that distal clavicle's articulation with the acromion process is something that we can find if we're having difficulty by palpating the spine of the scapula and bringing that palpation all the way out here to that. And then the last thing I want to draw your attention to for this lab is the angle of the scapula. And so I know that you guys have palpated this before, but what I want you to understand is that that these are not stationary landmarks. These are landmarks that move around, and so because of that, we need to be able to identify where they are. And I have seen it before where when asked to palpate the scapula, we go to where we think it should be instead of where it actually is. And so it is important for us to be able to identify that angle of the scapula. It's important for us to be able to identify that spine of the scapula as some really great landmarks for us to help us know what muscles are maybe overactive if we're doing a postural exam, where are we having tenderness, where do we have joint restriction or excessive joint movement, etc. So this is the osseous landmarks of the shoulder complex, and then we'll move on to showing those on a patient. All right, let's take a look at those osseous landmarks here on a patient. So we're going to start with the SC joint. So the SC joint is the proximal clavicle and the manubrium. So what I want you to do is find that proximal, or find the clavicle itself, and then work your way proximal until you feel a ridge or a bump, and that's the end of that clavicle. So we have a proximal clavicle here. And then if we go beyond that, we land on the manubrium. The manubrium, you can kind of see this little bit of a U shape here. The manubrium sits right here, and that's what that clavicle articulates with. So for the SC joint, the sternoclavicular joint, that's where that boundaries of that joint are. Now we can palpate this joint here and take my patient's arm and do just a little bit of a circumduction, and I can feel the motion that exists at that SC joint. The next thing I want you to do is I want you to palpate the entire course of the clavicle. So as you're palpating the entire course of that clavicle, remember that clavicle jogs back, and with my patient's permission, patient may have permission to move this strap over just a little bit. We're going to move so that we can expose that AC joint. That clavicle jogs back, and then as we get more distal, that clavicle ends, and then the acromion process comes over the top. Remember I said in the anatomical model portion of this that you could use that spine of the scapula to help you out and come up over and land on that acromion process. And here is that acromion process. Okay. And so I have a patient kind of lean forward just a little bit there, and we can see that acromion process as it sits here. Okay. The next thing that we need to identify then is the coracoid process. We said the coracoid process was important because there's some muscles that attach there. We've got pec minor, we've got coracobrachialis, and then we've also got the short head of the biceps. And so to find that, we're going to find the AC joint and fall down. We fall straight down, we're going to land on a deltoid, and we'll work just in. And there'll be this bump that exists here. You can kind of see my hand kind of move over that bump. And that's that coracoid process. Remember that it is a very tender palpation. So use very light pressure as you're going through on this palpation. Okay? It'll be important that we need to realize that these attachments that exist here, you can have your patient do resisted flexion at the elbow. So like they're going to make a muscle here, and then you'll resist, so hold here, I'm going to push, and you'll feel that biceps attachment pop, nice and relaxed. And again, push, good, and relax. And you should feel that biceps tendon pop. The next palp that we're going to do here is the GH joint, as you hear my dog in the background here. So that GH joint here, we've got the humeral shaft here, the head of the humerus here. And so what we need to do is we need to palpate that humeral head. And I said sometimes it's difficult to find that humeral head because we have that deltoid that sits over the top here. So if that deltoid's sitting over the top here, we said that we could take that attachment of that deltoid down here on the shaft of the humerus, and we could work our way back up. And so if we do that, we find the shaft of the humerus, and then we work our way up to the head of the humerus. And so the head of the humerus, actually the outline of it is here and here. And so there's this little bit of a, it doesn't sit just immediately lateral here, and that's because a lot of us sit with these anterior shoulders. Our shoulders are rotated anterior. And so we can feel the head of that humerus here, and we should be able to pinch and move that head of the humerus. The last thing that we need to palpate is the scapula for the scapulothoracic joint. So I'll have my patient turn around and face this wall here. And so what we need to be able to identify here, patient, can I move this over just a little bit? All right. And so we have that spine of the scapula that sits right through here. There's that acromion process. That spine of the scapula kind of does this number and comes over. It doesn't have that sharp of an angle to it, but it has that little bit of an angle as it comes down through. And then I need you to find the inferior angle of the scapula, which is right here on her. Okay, we need to understand that inferior angle of the scapula, or that scapular angle, is going to move when I move the arm. So if I bring the arm out into abduction, it starts to rotate around. Now it's way over here. So I want you to be able to do that. I want you to abduct and adduct the arm, palpating that inferior angle of that scapula, feeling the motion that exists there. And those are the osseous landmarks of the shoulder complex that we're going to cover here in lab.